Welcome to another edition of Back Talk, brought to you from the Southeastern Studios in Mount Pleasant, South Carolina. Each episode, you'll hear from board-certified physicians as they explore the latest in medical procedures that are now helping get more and more people out of pain and back to their active lives.
So welcome back to another episode of Back Talk. I'm Dr. Ben Schell. I'm here today, joined by a man who needs no introduction, honestly. Dr. Dustin Hambright, a hip and knee specialist, also with Novant Health. Thanks for joining us. I appreciate it.
Thank you very much.
We were hoping to kind of just get it right into the problems that we share between our two clinics. So I'm a neck and low back specialist. Dr. Hambright does a lot of hip and knee replacements, and we frequently share patients, and we have become close colleagues as a result of that. And we were lucky enough to borrow some of his time today. So thank you for coming.
Thank you. I think I sent a patient to you today, actually. So this is fantastic. You're right down the street.
Yeah.
And all the time, hip knee pain syndrome, hip back syndrome patients.
Oh yeah.
All the time.
All the time.
Patients coming in with hip pain, get an X-ray, and voila, they have no hip arthritis.
Right. Looks perfect.
And like, doc,
pristine.
My back, my hip, and they're so surprised because I get an X-ray and I'm like, you have no arthritis in your hip.
Right. It looks perfect.
This looks perfect. And I'll go further into their history and their pain, and like, oh, doc, it kind of goes down my leg. It goes to my knee, goes down to my foot. Have a little numbness.
Not a lot of hip arthritis causes numbness.
And I say, hey, sometimes people have back issues that sort of is actually felt in their hip or felt down their leg.
Yep.
And then, lo and behold, I say, it's your back. And then I will send them to you.
Oh, yeah.
I'll say, hey, I got this spine team down the street, Southeastern Spine.
Oh, yeah.
And I'll refer them to you, and next thing you know,
boom. Yeah.
They come to you, and what happens?
Oh, yeah. So, I mean, usually I try not to repeat, the work. Like, if they're like, hey, it's not her hip, I'm not going to get the new X-ray or anything, and trust you ruling that out for me. But, yeah, I mean, they do the same thing to me where they're saying, it kind of hurts here or here. It's in this vague gray area of hip, low back, coming down the leg. And so, yeah, it's something where once we're seeing that it's not the hip, but you're still having that pain that feels like it's your hip, then it's going to be one of those nerves at the bottom of your spine. It could definitely be also one of the joints in the bottom of your spine with your facets. And it's just that all of that motion is in that one spot. You got a complex hip joint, you got the sacroiliac joint, you got the facet joint, all these joints that are in a space about this big, and it can just have a lot of complex pain right in that muscle group. And so, yeah, so then we're looking at it, we're saying, hey, look, we've already ruled out your hip, check that box, moving on. And then we get the MRI to say, look, is it coming from a nerve? Is it coming from the joint? But I think the perk of this is that for people who are busy or driving from far away, you and I not only have a good collegial relationship, but we are like distance-wise, walking distance, and to get people in same day or very quickly is probably the best sequence of all of it, because we can rule out all of these things quickly. And same, it goes the other direction where I'm seeing somebody who's saying, it really hurts in my back. It's really my back. And because of everything that we've talked about in the past with how closely these things overlap, all of my patients with back pain get an additional hip X-ray to rule that in or rule that out, so that, hey, look, I know your back may hurt a little bit, or you may think it's your back, but it's that hip right there with a lot of arthritis. And then we send you down the road.
I think I've had a patient with you the past few months where they came to you in the morning, you ruled out their back, thought it was their hip, sent them to me, and by the afternoon they're in my clinic, got a hip injection, and they're walking out with pain relief from what they first thought was the back, lumbar spine.
Yeah.
Now they're walking out with a hip arthritis diagnosis and relief after having a hip injection.
Yeah,
so
the proper diagnosis.
No,
right?
that's an awesome part about sort of being so close and having a collegial sort of relationship. So that's a great thing about Novant and about Southeastern Spine and Orthopedics coming together as one. And I'm excited about the future with everybody.
Yeah, for sure.
Yeah.
I don't see a lot of where it becomes a knee problem. I don't know if you see that, like once they get to you, if I'm like, hey, look, it's not their back, do you see it where it's actually, oh, well, your hip looks fine, but, is that, I mean, I guess that's kind of a deficit in my training along the way. Like, does it become a knee problem, or is it a knee problem?
What, from a hip?
Would you, in theory, have hip pain from knee arthritis?
So it's funny you say that. Sometimes people will come in with a knee pain.
Sure.
And it's completely normal x-rays. Same thing. It's sort of come in, my knee hurts, get x-rays, knee looks great.
Sure.
And then you sort of, and during the exam, you start moving their knee up and like their hip starts hurting. You're like, wait a minute.
Yeah.
This is totally your hip.
Sure.
So knee's perfect in x-ray. Then you're like, you send them back to x-ray and their hip is just torn up and degenerative, and their hip doesn't hurt. That's the funny ones. And I think that one of the coolest things is when you bring them back, you do a hip injection, and their knee pain goes away. And they're like blown. They think you're like a magician. They're like, what are you talking about?
Or you're crazy. Why are you injecting my hip? My hip doesn't hurt. It's my knee.
And their knee pain goes away, and they're like, you think you're like a genius. You're like, no, I'm not a genius. I just, I learned this in residency because in residency, the cardinal sin of pediatrics. Remember. So if you get a kid comes in with knee pain, and you don't get a hip X-ray, that's like the cardinal sin because they could have a hip problem. Right. They could have an infection, herpes, fracture, a skiffy. Like, you're toast. If in morning, presenting the X-rays. Yeah. Oh, this kid came in last night with knee pain.
He's fine.
We sent him home. You're just
get out of here.
Yeah. Just start packing the bags. So same thing with, now we're, with adults, people come in, knee pain, not their knee, it's their hip. Hip pain, not their hip, it's the spine.
Yeah.
Or spine pain, not their spine, it's their hip. So you got to be on your toes. But the best thing, having, all these people around is that, you don't become a hammer. When you're a hammer, everything's a nail.
Sure.
But when you have guys around you, I have Dr. Schell's, I have Dr. Harrow, I've got SG's, McCoy, Dr. Schutte, and all your partners. Not everybody's a nail. Like there's subtleties that you can send to help rule out a back, rule out a knee, rule out a hip. That you can you have all these options to help figure out the patient's problem.
Yeah, I mean, you and I are always talking about the ones that kind of fall into that gray zone where, their hip's not perfect. Okay, well, what do you think about their back? Well, I mean, there's a little bit, of pressure on that nerve. There's a little bit of arthritis on that same side. Maybe we start ruling them out one at a time, which one's bothering them the most. And it's the same thing, as you kind of walk through these different channels because we're not on an island, right? You're not on an island. I'm not on an island. We're not, stuck in our little ruts of, just treat everything this way. This is the algorithm every single time. We're thinking outside that box. We are bouncing ideas off one another. We're reviewing the same scans, having a second set of eyes, having a second, educated person looking at these things, saying where else could this be coming from? Because it's just not sounding like a home run from a spine or hip or knee or wrist or hand or whatever. It's not sounding like a slam dunk from that. What else could this be? Yeah. And so I think that's really where we shine as a collegial group of kind of having everything covered from head to toe orthopedically, that we can tease these things out of, I realize that it may be a little bit of nerve pressure here, but you got so much relief from that hip injection. This is where we need to focus our efforts, because I feel like you and I are always kind of kicking ones around of like, what should we do here? And, the nuances of, operating here first or injection here first, and just kind of moving the pieces around really help us both kind of build up from that of not going down the same path every single time, nail.
And the kicker is, too, it could be both.
Right? Yes. The number of people that have been both are not zero, right? Like the amount of people that either, you've done the hip first and hip feels great. And then, 2 years later, they're like, hey, it's my hip hurting again. Bam. Or vice versa. Right.
No, it's right. I can blame you for things.
Joke's on you.
It's the spine guy.
Go see the spine guy.
Well, but no, thanks for having me.
No. It's been great. It's always good to see you.
Thanks, bud.
Yeah.
Take care.
Oh, yeah. So thanks again to Dr. Hambright for coming by and stopping by. Always good talking to you. And then, join us next time for another episode of Back Talk.
We hope you enjoyed this edition of Back Talk and learned something new. Look for other podcasts from Southeastern Studios as we explore the latest in medical procedures that are helping more and more people living in pain get back to their active lives.